And there'll be some other.
But it's interesting. It's busy for things that you are in, but sometimes it's busy.
Sometimes it's very things I do what I really want to think I'll have.
Right.
Yeah, well. It went.
That's not that bad.
Yeah, but yeah. They might. No. Oh yeah, no, I did it. Yeah. I went there once with a friend. That was good. Yeah. But no, he was not here. No, not yet. Okay, welcome back, and welcome to those that are new to this part of the meeting. We're back in full session, and we'll move to item number 5 of the agenda, which is the board, which are the board and committee reports. And I will start with item 5A, minutes of the June 26 board meeting. And I'll ask if there are any corrections needed to those minutes. Okay, hearing none, I'll then ask for a motion to approve item 5A, the board meeting minutes of June 26, 2026. Can I have a motion, please?
So moved.
Thank you, Vice Chair.
Second.
Thank you, Director Harrington. Is there any discussion? Are there any comments? Okay, there are none. All those in favor, say aye.
Aye.
All those opposed, say nay. Okay, the motion carries. We will now move down to item 5B, minutes of the July 10th, 2026 Audit and Compliance Committee meeting. And I'll ask my colleague, Director Harrington, to review those, please.
Again, the Audit and Compliance Committee met on Friday, July 10th at 9 a.m. Our next regular meeting is scheduled to be held on Friday, October 16th at 9 a.m. Nicole Amiro, Chief Corporate Compliance and Privacy Officer, reviewed the report, which included information on the following subjects. Metrics 1 and 2 for the first and second quarter of Cook County fiscal years 2026, Systems Compliance Program, the County Care Medicaid Health Plan Compliance Program recoveries. There was also a report on compliance education and training update. The committee did go into closed meeting to receive reports, but there is no plan to re-review those today. So the minutes can be approved at this time.
Thank you, Director Harrington. So I will ask for a motion to approve item 5B, the minutes of the meetings of the minute of the Audit and Compliance Committee of July 10th, 2026. Can I have a motion, please?
So moved. Second.
Thank you. Same two folks are working hard today on those motions. Are there any comments or discussion? Hearing none. All those in favor, say aye.
Aye.
All those nay. Hearing none, that motion passes. We'll now move to item 5C, minutes of the July 10th, 2026 Managed Care Committee meeting, and I'll ask my colleague Vice Chair Lowry to review, please.
Thank you, Chairman. The Managed Care Committee met on Friday, July 10th at 10 a.m. The next regular meeting of the committee is scheduled to be held on Friday, October 16th at 10 a.m. And as I shared with the committee, my birthday is October 21st. Should anyone feel an overwhelming need to give me a gift, I will accept it. But during the meeting,
And unless you have a pre-existing relationship, you may have to, be aware of all the limits. So.
well, that's why I need you close. All right. But during the meeting on July 10th, the health plan staff presented a report which included information on the following subjects: health plan metrics, strategic initiatives and priorities, which included transformation and growth, Health Choice Illinois contract implementation, state legislative session wrap-up, HR 1 preparation, quality, safety, and experience, CCH's HEDIS performance and next steps, CCH's CAPS performance and next steps, the Health Equity Accreditation, and the Fiscal Resilience Project. There are no questions or further discussion needed on this information. The meetings can be now approved.
Thank you, Vice Chair Lowry, for the review. And so I'm asking a motion to approve item 5C, the minutes of the meeting of the Managed Care Committee of July 10, 2026. Can I have a motion, please?
So moved.
Thank you, Director Harrington. Is there a second?
Second.
Thank you. We switched it up there. That's good. Are there any comments or discussion regarding this motion? Hearing none, all those in favor say aye.
Aye.
Aye. Oppose, nay. Hearing none, those minutes are passed. That motion is passed. We will now move to item 5D, which are the minutes of the July 24th, 2026 Quality and Patient Safety Committee meeting. And given that Director Sorrell is remotely participating, I will step in on behalf and review those. The Quality and Patient Safety Committee met on Friday, July 24th at 9 a.m. The next meeting of the committee will be held on Friday, August 21st at 9 a.m. The committee approved the following action items, which are included in the minutes. Approved Stroger and Provident Hospital medical staff appointments, reappointments, changes as amended. The committee received the following reports, which are included in the minutes: the Quality and Patient Safety Updates Dashboard, overview for Stroger Hospital, Provident Hospital, ACHN, CIRMAC, the Cook County Department of Public Health, and County Care. The committee also received a closed meeting report. If there are no other questions on the minutes, they are being presented to the board's consideration at this time. Are there any questions? Okay, I'm asking for a motion to approve item 5D, the minutes of the meeting of the Quality and Patient Safety Committee of July 24th, which included approval of the following items: the Stroger Hospital and Provident Hospital medical staff appointments, reappointments, and changes as amended. Can I have a motion, please?
So moved.
Seconded.
Thank you. Thank you for the first. Now it's a competition.
I'm back.
Yes. It's been first and seconded. Any questions or comments, please? All those in favor say aye.
Aye.
All those opposed, nay. That motion passes. Moving right along, we'll go to item 5E, minutes of the July 9th Finance Committee meeting, and I'll ask my colleague, Director Ryder, to review, please.
Thank you, Mr. Chairman. The committee considered the following action items, which are included in the minutes. We conditionally approved 19 contracts and procurement items. Request number 15 is pending review by contract compliance. On the screen, you'll see the contractual requests from the Finance Committee meeting, whose fiscal impacts are greater than $1 million, which are highlighted for your information. Of note, with regard to the proposed request to extend and increase the contract with the Chicago Lighthouse for patient telephonic support services, request number 13. Directors Lowry, Robinson, and Harrington stated that they look forward to continuing the conversation on that subject, including past the new contract expiration date of February 2027. Director Lowry requested that the committee receive a report on an annual basis on the percentage of Cook County health vendors who do and do not have a physical presence in Cook County. We received and filed grant award related items. The committee received the following reports, which are also included in the minutes: report of May financials, report on the Guidehouse recruitment update. The next regular meeting of the Finance Committee is scheduled to be held on Thursday, August 20th at 10 a.m. Additionally, the Finance Committee will convene a special meeting today after the board meeting concludes to introduce the proposed fiscal year 2027 preliminary budget, with public hearings to be held on Monday, August 10th at 6 p.m. and Thursday, August 13th at 10 a.m. I would also note that in approving the contractual request that I recused myself from request I abstained. I didn't recuse myself. I abstained from request number 13. If there are no other questions, the minutes are being presented for the board's approval. And again, going along with that, Mr. Chairman, I will be, to the extent that the minutes adopted by the Finance Committee reflect approval of request number 13 that was considered by the Finance Committee, I am abstaining from that.
Clearly noted. Thank you, Director Ryder. So I'm asking for a motion to approve item 5E, the July 9th, 2026 Finance Committee meeting minutes, which contain the following action items: conditional approval of the contracts and procurement items pending review by contract compliance, and receiving and filing of the grant award related items. Can I have a motion, please?
So moved.
Thank you. Thank you, gentlemen. Are there any questions or comments?
Hey, Mr. Chair,
Yes, sir.
I'd like to state I'm recusing myself from item number 12.
Okay. Recuse or present?
Or abstain, sorry.
Abstain, okay. That is noted. So I believe we have a first and second. Is there any discussion or comments? All those in favor say aye.
Aye.
All those opposed, nay. That motion passes as well. Moving on to item 6, contracts and item 7, report from the chair. So as I've said in previous meetings, I've been working very closely with Dr. Makaitis to really understand in a comprehensive way, in a vertical way, probably horizontal as well, the ongoing the total operations of Cook County Health. So I want to focus on 2 areas in my report. Provident on-time surgeries. So there's a continued work through the multidisciplinary team to implement targeted strategies to improve operating room access, to optimize surgical throughput, and to enhance efficiency across the system. So that's fantastic that we're really trying to optimize those resources for the benefit of our patients. And so there is progress being made. These efforts have resulted in Provident Hospital's percentage of first case on time OR starts, bless you, increasing from 38% in March, in just 4 months to 79% so far in July. So I want to congratulate you. I think that deserves some applause.
Well done, team.
That's what I would say, rapid improvement, but I'm also confident that it'll be sustainable. So it's especially important as we continue to grow outpatient specialty care and ambulatory surgery at Provident Hospital. What I would also add is that it's clear that the greatest demand of services at Provident continues to be for outpatient services. We want to provide patients with the services they need at the time they need it, and the place they need it. And with initiatives like this one, this OR optimization, it really illustrates to us that we can increase our capacity to care for even more patients on the south side, as we will see that demand increase over the next 5 months when things happen on a national policy level. So that completes the first part of my report. I'm going to move to weather response, which I hope that if any of us experienced that it was minimal impact on your personal life, because we've seen some wild weather patterns over the last several months, especially. And it's not been easy for the team at Providence Hospital during the hot weather. And Dr. Makaitis has been great at getting out these bulletins to the board in a timely manner, really in a real-time manner. And so during the hot weather we experienced this month, Providence HVAC system has been exceptionally stressed, like other HVAC systems have been in other systems, including healthcare systems. And because of that, it's impacted clinical operations, as we've been briefed on in those memos that the Secretary has sent out. The rain and high winds just this past week also had an impact on multiple Cook County health sites, including water damage and multi-day power outages, which really we have no control over. So through each of these challenges, our teams remained focused, and I think that's what I'm proud of, on what matters, and that's providing what matters most, and that's providing safe, compassionate care for every patient who came through those doors while we were navigating these natural events. Even while many team members were managing storm damage and disruptions in their own lives, they continue to show up to work with the professionalism, resilience, and a commitment to the communities that depend on the Cook County health system. I'd especially like to thank the facilities teams and the ACHN teams for their coordinated around-the-clock response, as well as the many individuals who stepped up in their own ways to support the team across the system. That level of dedication speaks directly to who we are as an organization, and especially to our mission. So I'll close with this. On behalf of the board, I want to thank everyone who had a part of these weather responses that were really unprecedented and in many ways unpredictable. Your efforts and commitment are invaluable, and I want you to know and feel that they do not go unnoticed by the board of directors. So thank you. Thank you for continuing to keep me updated, Dr. Makaitis. I will now move to item 9, which is an informational report, and this will be an update on the Regional Behavioral Health Strategic Plan 2025 annual summary presented by Dr. Thomas Nutter, Chief Behavioral Health Officer. Welcome to the table.
Thank you. Good morning, directors. Again, Tom Nutter, Chief Behavioral Health Officer for CCH. We are grateful for the support of this body, for our office, and for your support of this initiative in particular, and appreciate the time this morning. I'd like to use that time to briefly review the process used to create the Regional Behavioral Health Strategic Plan for Cook County, to provide an overview of the document that we sent to the board back in May on an implementation summary. That was implementation through the end of 2025. Then update the board regarding next steps in implementation. And lastly, to make sure everyone has an invite to the Mental Health Summit. This is the second All-County Mental Health Summit coming up on September the 9th. Next slide, please. I'd also like to thank the members of our staff who are present here today all of our staff for their great work, but particularly those that are present today, Dr. Brothers, Dr. Nowinski-Konchak, Mr. Lee, and Ms. Williams. So the idea of the Regional Behavioral Health Strategic Plan for Cook County was to create a common blueprint, one sheet of music for all agencies providing mental health services throughout the county. And the process for creating that document was extensive. We began in 2024 with essentially a lot of information gathering. So at the summit, which many of you were present for, we held an all-day event that was a day of structured listening, lots of time with butcher block paper, Mentimeter surveys, all kinds of input from the 300 or so agencies and over 700 folks who were there that day. Then later that summer, we had completed a community needs assessment using publicly available data, including community needs assessments from several local hospitals. That was published in the summer of 2024, and then also in 2024 convened, along with our partners at CCDPH, a behavioral health workforce assessment that culminated in a symposium in October of 2024. Next slide, please. We then, as the plan was being crafted, vetted that plan on several occasions with an intergovernmental work group, whose work is now ongoing. That includes representation from the President's Office, from the Chicago Department of Public Health, the Cook County Department of Public Health, other branches of county government that have behavioral health programs, and as well as state mental health leadership across several state agencies to make sure there's alignment across agencies and agreement on the language of the document. And then lastly, as we had almost finished the document, we had 5 sessions, one for each priority area with community partners. Those were very well attended. Over 500 people attended when you add the 5 meetings together to provide kind of final commentary and edits. And the plan itself was released, as I mentioned, in May of 2025. The vision for the plan, as listed here, is to foster a healthier and more resilient county where all residents have equitable access to timely, comprehensive, compassionate, and high-quality behavioral health services, a county where behavioral health care is prioritized as an essential component of overall well-being and where support is integrated and available to everyone, regardless of background, circumstances, or zip code. The guiding principles for the document are listed here. Next slide, please. So the 5 priority areas that we settled on are listed here. Systems alignment, because anything that we try to do in a public health space has to involve alignment with all partners and have an organizational structure that creates sustainable success. Priority area 2 was workforce development, given the substantial needs we have to bolster our workforce in behavioral health. Priority area 3 was behavioral health services for children, youth, and families to make sure we're being preventive and addressing mental health issues as soon as possible. Priority area 4 was access to treatment, support, and recovery. And lastly, priority area 5, crisis system enhancement. Next slide, please. So going through each of the priority areas, priority area 1, for priority area 1, there were 3 goals listed here. One was engaging stakeholders at a hyperlocal county and state level, then creating standardized metrics for data-informed decision-making, planning, and evaluation. That one's been a little trickier to implement than we might have anticipated. And third was optimize resources and funding for behavioral health to create a comprehensive and responsive system. I would add that the plan itself, as you know, is around 40 pages long, and the implementation document around 30, and including about 75 metrics or milestones. So we'll try to keep today at a pretty high level, but as there are specific questions, I'm happy to respond to those, and I'm sure our team would as well. Next slide, please. So for systems alignment, I'm happy to report that the regional behavioral health collaboratives have already, this is really where the work is going to happen at the community level, where feedback is going to be received and where the action really takes place. Happy to report that all 11 of those, and again, keep in mind that the 6 in Chicago align with the Chicago Health Equity Zones, and The five suburban ones correlate essentially with the regions used by CCDBH with one small tweak. All of them have established charters. All of them have elected co-chairs. All of them have strategic leads and action plans. They all 11 recently completed a second round of in-person convenings, and there is again a lot of momentum happening in that front. The intergovernmental work group I mentioned, and it seems odd maybe to highlight just a quarterly meeting that's happening, but since this meeting wasn't happening before, and I think it's essential for the alignment of all parties concerned, we do think that's an essential cog in ensuring the success of the plan. So in terms of next steps, we'll continue those intergovernmental work group meetings, and likely those are becoming more topic focused as we go forward. We're in the process currently of completing a countywide assessment of community-based organizations' infrastructure and capacity specific to billing. We have a lot of organizations, especially smaller organizations, that are providing therapy and in some cases case management on health-related social needs that may be either billable now or soon to be billable through the 1115 waiver, and trying to figure out ways that they can maximize revenue. And even though that may not necessarily be a lot of money in these times, we think it's essential and will be an important addition. Lastly, an OBH website. We've just seen the first draft of this website this week. We'll be, I'll commit to having that to all of you by the time of this meeting next month. And I will, just to give a quick preview, say that our whole team was very impressed with the product, and we think it's not only going to be a comprehensive place that community members can go for as a resource, but also something that is aesthetically doesn't look too busy, and I think will be very well received. So under workforce development, we essentially pulled the goals for this directly from the symposium. The plans were to try to improve wages, to try to improve the pipeline for behavioral health workers. How the tagline being, how can you choose a career you don't know this? The third was to create a learn and earn pathway, and I italicized that because I think it's particularly critical, and we'll say a little bit more about that here in a minute. The fourth goal was fourth objective was to improve the quality of behavioral health jobs, and then fifth, to reduce administrative burden and try to improve efficiencies. There was a lot when the workforce report came out. The big headline was that in order to meet all the needs of Cook County, all the behavioral health needs of Cook County residents, we would need to hire almost 30,000 new staff before the end of 2028. But underneath that big headline were also a number of important findings that I'll just remind the board. One was that the behavioral health staff are not geographically distributed well, that there is a significant shortage of men in the workforce, that Black staff are underrepresented in the higher paying specialties, but overrepresented in some of the lower paying specialties, and that Hispanic and Latinx staff are underrepresented throughout all of the disciplines studied. Also, I often add, next slide, please, that the biggest dissatisfier among nearly 1,000 people surveyed for the project was the inability to get my clients the services that they need. So where have we gone progress-wise? This is the first item here is one of two things I'll present that we don't get any credit for, but I'm happy to announce it anyway. At the 2025 behavioral health salaries compared to 2023 increased across all 16 occupations in fairly dramatic fashion. All the increases were 19% on the low end, up to 56% compared to 2023. And again, this is the same group doing using the same methodology that they had almost exactly 2 years previously. I'm also happy to report that thanks to some great work by Dr. Brothers and her team, a behavioral health apprenticeship and retention hub has now been created that's brought together more than 20 employers, 5 academic partners, some workforce partners, and governmental stakeholders to expand career pathways, essentially bringing the very staff that in the areas where we're most deficient and groups that are most underrepresented into the workforce. And more than $1 million has been secured for projects related to this. The first cohorts for CADCs and Certified Recovery Support Specialists have now begun. That's the one area where we sort of cheated on the implementation document that you received, because that started in 2026. Everything else was as of the end of 2025. And work groups have been convened regarding implementation of collaborative care, which I know is a particular passion of our chair, and regarding the use of AI. So for next steps, really the big thing here is we've created the hub, and it just needs funding. The structure is there, the partnerships are there, the need is there. There's a great deal of capacity there. We just really need to focus on funding that in the next year or two, and are optimistic for the growth of those programs. We're expanding outreach to mental health careers and developing strategies to expand integrated care models and improve efficiencies. Next slide, please. So the next slide is just, I'll describe it as we're getting to it, is just showing some of the, some details about the two learn and earn projects that have now started, and also, which I didn't talk about in the previous slide, a new program. I mentioned earlier this tagline about how do you know to choose a career that you don't know exists. Is it literally a pre-apprenticeship program? So one more, please. This one. So there's, on the right here is a flyer for the pre-apprenticeship program that's been a joint venture with Association House for folks who are just considering careers but aren't quite to the place of committing to one of these pathways. Next slide, please. So the third priority area is behavioral health services for children, youth, and families. And it contains the 4 goals listed here. And I'll move on to the next slide in the interest of time. I will say on this one, as you look through the implementation document, there are a number of items in the metrics in which we've written anticipate update in 2026 or 27. There are a number of those here, and so we recently met for an implementation retreat and have assigned all the tactics to particular team members, and we'll be moving forward with a lot more specifics in the coming year. Most of our successes in the children, youth, and families realm have been through the Stronger Together program that was previously presented. Update was previously presented a few months back, but through 2025, over 11,000 families have been served and more than 4,000 demonstrated quantifiable improvements in outcome. 10 of the 11 regional behavioral health collaboratives had chosen to prioritize children, youth, and families as priority areas. And this next item is the second thing we don't get credit for in this presentation, which is effective in 2027 and 28. Mental health screenings must be offered to all students grades 3 through 12 throughout Illinois. So next steps include supporting the Stronger Together grantees as they transition beyond ARPA funding. About 30% of them do have some capacity for billing. About 40% we're working with to try to improve their potential capacity for building. About 30% do not. So we know some of the projects will likely end, but most we think will continue. Under next steps, we also I've gotten a lot of feedback on resource directories. That's come up at pretty much all of the regional behavioral health collaborative meetings. And so and we recently completed a survey looking at what resource directories folks use, et cetera. And in the coming year, we're going to be exploring trying to create some kind of hub and spokes kind of model so that those resource directories can be updated regularly in ways that are a little bit more efficient and effective and can be maintained in a more sustainable way. And lastly, we want to expand training opportunities, including youth mental health first aid and other evidence-based therapies. While I have a minute here, I also want to use this time to make an announcement. As of 11:44 last evening, we were notified, and this is relevant for the children, youth, and families, that we had been awarded SAMHSA Children's Mental Health Initiative Award. That's for a project called Care Connect Youth. It's a joint venture between OBH, a Safe Haven, Chicago Public Schools, and Noble Charter Schools, as well as a lot of other community partners. So thank you, Dr. Brothers, for that and for that great news that we just got.
Great news. That comes along with funding, right? How much money are we talking about?
$1 million a year, sustainable for 3 additional years after the first year. Next slide, please. So under priority area 4, this largely has focused on improving access for the adult population, improving quality of care in the adult population, and reducing opioid deaths. Next slide. In terms of the NAMI helpline, the reason we have prioritized this, and this was using our corporate dollars initially, and will be using corporate dollars in the future for this. There are very few initiatives that can benefit the entire mental health system as a whole, and having NAMI as a common access point, we think is a very helpful intervention, and one that we're happy to report is now receiving about 1,000 contacts a month, and over 300 of which of whom are calling to be directed into clinical services.
And NAMI stands for what?
Say again, I'm sorry.
NAMI stands for what?
National Alliance for thanks for the mentally ill. Thank you. I'm also happy to report that though we have a long, long way to go, that opioid deaths, as I think we all know, have substantially declined over recent years. The numbers are presented here. The 2025 data are not final. There are, I believe, about 18 cases that remain unconfirmed as of a meeting last week with the medical examiner. So the total for 2025 may be below 800, which would be a more than 60% drop over 2022. But as we all know, it's still far, far too many. The deaths are in particular communities are certainly devastated more than others, and we remain committed to expanding treatment options and to expanding harm reduction efforts as well. Next slide, please.
Just on this one real quick, did I see an article that said Cook County was the largest decline in the entire country as far as counties go related to?
I have not seen that, but there's certainly been a lot of collaboration at a lot of levels by a lot of different organizations. And so I wouldn't be surprised if that were the case. I don't know that to be true. But
I'm sorry, that's your question.
Yeah, feel free.
I think Director Bott wanted to.
Well, I was just going to say, it's just looking at the numbers and the amount of work that's gone, I just applaud the tremendous effort on this really important initiative that's helping save lives.
And I was referencing an article I saw maybe a month and a half ago that decline that Dr. Nutter was just sharing is actually the largest decline as county by county across the country.
Wow.
Cook County had the largest decline.
That's impressive. Wow.
I'll go get those numbers and make sure that we put it up on a graphic somewhere.
Absolutely. And then lastly, and I put the content for this onto one slide. The final priority was crisis system enhancement. Even though this is only one slide, I think a brief commentary is probably warranted on this. Our current crisis systems of mental health care are far from perfect, and flaws within that system and flawed people within that system have not only not been as helpful as could be the case, but have caused, in some cases, really tragic harm and harm that has disproportionately affected communities of color. And so it is imperative that we collectively, and I say this, at a federal level, at the state level, at the local level, at the OBH level, that we address these concerns and try to move that system forward. Some of these conversations are politically challenging. A lot of them are very emotionally charged, but there is no turning back. That having been said, as we get into the weeds, it's worth noting that the changes in the system are both relatively recent and evolving, and are also operationally complicated in certain ways. Like so 911, I believe the first 911 call was in something like 1968. 988 was just rolled out 4 years ago. And as such, a lot of folks are still not aware of 988. There's still a lot of places where there's an unwillingness to utilize 988. There's some challenges with data with tracking 988, since you don't have to give your location. How do you track at a regional level where the calls are coming from? There are challenges with 911 operators who may only have a minute or two with a caller. Right now, there's very little transfer of calls from 911 to the 988 system. And if you think about that from an operator level, it's a challenging thing to say, in 1 minute, I've ascertained that there's not enough risk that we need to involve police or fire, so we're going to send our mobile crisis team. That's not an easy paradigm shift for folks to make. There's I think a fair amount of variance in how mobile crisis works, even within our local area. Some challenges in reconciling how the system works for kids versus how it works for adults. There's been a lot of emphasis on living rooms at the state level, and I think the jury's still out on how that's all going to go. And I think it's also worth noting that as we talk about our critical shortage of staff, particularly in disinvested communities, investing in a staff to work in a crisis system where they may see 1 or 2 patients in a day, first, who are, to try to strengthen the net, the safety net, versus using some of those same staff to keep people from falling off the trapeze or from being on the trapeze in the first place. So these are tricky questions. And so I think the stance of our office needs to be, we need to be in the center of the conversation. So, with the national folks and how things are going elsewhere, what's working, what's not, with state, and certainly with the regional behavioral health collaboratives, as these kinds of things are, critical to be. It's critical to have these conversations at a local level. So back to the slide. Sorry for the sidebar. We have been collaborating with state and local agencies in crisis care initiatives. We are in full support of CCDPH's assessment of the suburban system and the recommendations therein. We are participating in the RACs, the Regional Advisory Committees for CESA, and one of the Stronger Together projects, actually I think this was the last one to be added, was just amazing, if you get a chance to see this, Youth Stabilization Center run by Ada McKinley in Englewood, and we're happy to have provided the funding for that, and that's going to be a sustainable program going forward. So moving on, I know I'm taking a lot of time here and apologize for that. But we'll skip the summary slide because you already just heard me say all this stuff. On to the summit. So the summit, as I mentioned, is September the 9th. This will be different than the previous summit, which was focused on information gathering. This is really much more of information sharing and networking. Our theme this year is going to be driving action to impact. As of this morning, the capacity for the venue is about 800. As you know, the invitations went out last week. We're at 762 this morning. So we are obviously holding slots for commissioners and electeds as well as board members. But do let us know if you can make it. We'd love to have all of you there if possible. So again, thank you for the time.
I do have some questions, Dr. Nutter. Thank you. That's a very comprehensive presentation, as evidenced by the 60 slides. A lot of good things happening. So, and thank you for acknowledging my interest, if not passion, in the collaborative care model. So what model are you looking at, or where from are you trying to glean the knowledge to implement that model or further that model?
We had convened a group to make recommendations on how to expand collaborative care, both within CCH and external to CCH.
Yeah.
And that report we haven't shared to this point. there are some specific recommendations and some non-specific recommendations in there. I don't know that we're likely to choose a specific model so much as it will be trying to move forward with whatever, wherever folks are at. I suspect as we, and this is not something we've discussed a lot as a team, but as we are rolling out, we're hoping to receive additional funding in the coming months for grant making. And this round of grant making will be a little different than Stronger Together 1.0 in that we're hoping to be a little bit more targeted. And that's a long-winded way of saying this is an area I think we need to target for that grant making. And I think we also, as you know, need to really look at this in terms of our own internal systems of care. I believe we need to do this. I know you believe we need to do this, and I've been waiting on a particular hire that is, I think, going to happen in the next few weeks. And so more to come on that. I know that's a little vague, but that's where we stand at present.
Well, I would suggest University of Washington. We've not looked at that model.
Yes, yeah.
Okay.
I mean, that's the mecca. They started it all really.
Very good. And
I know the University of Washington started these programs.
Yeah. And how many psychiatrists do we have on staff?
Right now, not counting the folks who are at CERMAC, I believe it's 6 or 7,
Okay.
with a few FTEs vacant.
So the reason I ask is because in my own day job, I've spoken with a lot of school district superintendents that are struggling. Their school systems are struggling because they're hitting a ceiling with what, as you know, child psychologists can do, therapists can do, and many of these young people, children, adolescents require more acute care because they present with more acute diagnosis where a medical intervention might be necessary. And so I'm wondering what that opportunity would look like. Maybe that's in the Chicago public school system, or maybe it's in other parts of the county. I know that there are a lot of interested superintendents that would be very interested in having that kind of support to help with that environment so that the youth could get the most out of the educational experience, and also the children or adolescents that are in school with those youth. So I'm wondering if you've thought about that.
Yes, love to have more conversation about that. That's and may even have some relevance for the grant we just were awarded that I just mentioned. So we're happy to include them in some of those conversations.
And also including therapeutic models for what's been a rise in cyberbullying as it relates to children and adolescents. And we saw just recently, I don't know, 3 or 4 months ago, where Congress had some intention around holding social media platforms accountable for the content allowance that unfortunately results in bullying and really trauma to these young people, children and adolescents. As it relates to MCR or mobile crisis response, at least as of today, I'm not aware of whether the state's released the rates yet, the new rates for that. Are you aware?
I don't believe so. We've been waiting for that as well. Greg? Oh, Greg's not here. I don't believe that's been, I haven't seen it yet.
Yeah, and I think that's...
I know we've been waiting as well to see that.
I think that's correct.
Not with the same level of anticipation you have.
Well, I think others have opted out because they haven't gotten those rates. And I know there are more, as you know, there are more requirements being placed on those providers. And it'll be interesting to see if the funding matches up with the ability to do that work. I think those are all my questions. Any other questions? Vice Chair Lowry.
Thank you. I have more of a comment. Thanks for the report, and I look forward to joining you and I guess 700 plus other people on September 9th. Want to just acknowledge and lift up a real thank you to you, Dr. Nutter, to Dr. Brothers, to the entire team for ensuring that the right to behavioral health care, much like traditional health care, is a right, and it's a right shared by us all as opposed to a privilege reserved for the few. And because of your efforts, we have countless residents in Cook County who are receiving the type of care that for years they just didn't receive, right? And I want to kind of make this personal because while that's important to me, it's equally important that I've had a family member who has recently taken advantage of these resources. And that's a testament to your work because that person's behavioral health episode was quickly resolved. So speaking on behalf of my family member and my family, I say thank you. And I say thank you to my dear friend, Dr. Turner. Unfortunately for him, he works in my district, so he always hears from me first and foremost. But I want you to know I truly appreciate you as well. The other thing I want to shine a light on, I am pleased that I passed a resolution which is creating a youth council at Cook County. So every commissioner will have a youth council person, and I think it's very important that we give voice to our youth. And they've got a lot to say. We just need to be quiet and let them say it. But I will, with your allowance, I'm going to lean on you and Dr. Brothers. I want you to be my subject matter experts because one of the pillars of that work, it has to be behavioral health. And Chair Garza, I'm going to lean on you as well because together we're going to make a real difference for our youth, and that need is acute. So thank you for that, but I have all of your cell numbers. Thank you.
Thank you, Vice Chair.
Thank you, Commissioner.
Any other questions or comments? Yes, Director Robinson.
Workforce Development, slide 51. Who are you targeting? I see the flyer. Who are you distributing it to?
Did you want to comment on that, Senator? So I'm asking Dr. Brothers to come to the mic here since this has been kind of her baby from the start.
Well, what we know in the workforce is that we, as Dr. Nutter mentioned, that the workforce, we need 50%. But we also know that representation is grossly lacking. And so we are working with small universities, community colleges, and targeting our communities where we have the most need in terms of workforce.
So the person that would occupy these particular roles would have a bachelor's degree in?
Some may not.
Huh?
Yeah.
Okay.
So we're looking at anyone, we're working in regards to our workforce, we're working with the Illinois Behavioral Health Workforce Center, and they have developed some materials to kind of really, as Dr. Nutter mentioned, how do you aspire to be in a career that you don't know exists? So we are working through the regional behavioral health collaboratives to kind of pilot those materials to increase knowledge and awareness to our high school students about careers in behavioral health, and then that pre-apprenticeship program. So we are working with the SNAP program to increase awareness to our pre-apprenticeship program, and that can target anyone from age 18 to, I think we had somebody who was 51 in one of the cohorts. We just finished the first cohort for that pre-apprenticeship program. But we really want to get like underrepresented communities into behavioral health because we know that representation matters across the healthcare system, but it is absolutely critical with behavioral health.
Okay, so what I would like to suggest is if you're looking here in the area, you can start with CPS and talk to the counselors, maybe to families who have been impacted by such. You may find an audience ready. And also I would definitely put forth, if you're looking for bachelor's level, look at the what do you call it? Career counseling at HBCUs. You may find a ready workforce that will solve your problem very quickly.
No,
That's my suggestion.
Absolutely.
Yeah. Thank you.
I know we're limited time, so I won't necessarily ask a question, but we can follow up offline. One, just thank you for the great work of the team on this really important issue. Two is I expect there's even more integration happening with primary care and ACHN and the health department. Third is I'm curious about how we're using technology, data across systems around getting out in front of crisis stabilization, so early detection and action, coordination, even with prevention, treatment, and recovery, and those efforts on opioids and substance use. So I'm curious about that.
Probably not well enough yet, is the short answer, but happy to talk more offline. Yep.
Thank you both. Very good update.
Great work, Dr. Nutter.
Yeah, for sure. And Dr. Brothers. So what was that? That was item 9. So I believe that concludes or exhaust the agenda. So, we're up to item 10, which is adjournment. And as the agenda is exhausted, I'll declare the meeting adjourned. Thank you. Have a great weekend. And